Hi, good afternoon, everyone. I'm Dr. Rajesh Vijayvergiya, Professor, Department of Cardiology, PGI, Chandigarh. It's always a pleasure and honor to be there at Manipal University to attend the scientific session. I'm thankful to the organizing committee, Dr. Dev, Dr. Ganesh, and Dr. Rao for the invitation. Uh, with the ongoing COVID endemic, I could not come over there personally and could not enjoy the warm hospitality of the institute. However, it's very nice that the Manipal University has continued the trend of the annual meeting, and this time it's at the digital platform. It's my pleasure to give a talk on the topic which is assigned to me is imaging guidance PCI, what is new in 2020. No conflict of interest regarding this particular presentation. As you all know about, there is a marked scope of imaging in a coronary intervention. You see the difference in resolution between, say, CT coronary angiography versus angiography, and a below diagram has very well shown the quality of picture of Mona Lisa. How does it improve with various investigation modality? In routine, we do use intravascular ultrasound and optical coherence tomography for the intracoronary imaging, and the resolution is markedly different between the two IVUS versus the OCT. The later one do have around 10 times more resolution, though the penetration is on the lower side compared to intravascular ultrasound. The table did show the merit of various imaging modality which are commonly being used for the coronary intervention. So this includes the IVUS, virtual histology IVUS, angioscopy, OCT, and near infrared spectroscopy. In routine, it's IVUS and the OCT. IVUS do have less of resolution compared to the OCT, but more of the penetration. If you see the assessment of the lesion severity, it's always been better to have a functional assessment by FFR, but then IVUS and OCT can very well give an idea about the percentage of stenosis one do have. Thin cap fibroathyroma can be very well visualized with the OCT. Identification of the necrotic core, it's the NIRS, the NIR, which has now more advantage compared to the routine angioscopy or the OCT. Optimization, which we routinely do use IVUS and nowadays with the OCT as well. And if you see the stent tissue coverage, it is very, very well defined along with the stent edge dissection and malapposition, which can be very well visualized with the OCT. Assessment of the stent failure at follow-up can be assessed by both the modality, whether it's IVUS or OCT. Regarding few landmark trial, which has given the edge of this imaging modality in coronary intervention, includes the clinical event. Is the stent diameter bigger is better? Yes, that is then true. When we started using the intravascular imaging, this particular study has shown that with the end minimal stent area after the procedure, higher it is, less chance to have now in-stent restenosis. You can very well appreciate that the in-stent restenosis is lesser with the sirolimus eluting stent compared to bare metal stent in this particular diagram. So this is the advantage, that bigger the area and better the clinical or luminal outcome is going to be. So in terms of clinical outcome, it's a target lesion revascularization and MACE at follow-up, which is far better when the area is more than, say, 6 millimeters square compared to those with less than 6 millimeters square. This is the standard diagram which we routinely been used during the coronary intervention. So this is the IVUS guided stent area across the left main bifurcation, and it's the rule of, say, 5, 6, 7, 8 to have a minimal area at various sites, which include ostial LCX, ostial LAD, confluence of the left main and the left main shaft. So this is the minimum area which is required to have a successful PCI and also the good outcome. But it doesn't mean that you are not supposed to achieve the area which is bigger than this. So sometimes the vessel size is too large, and then you can achieve the area which is bigger than say 5, 6, 7, 8. Few of the trial regarding the OCT, which has recently been come into the picture. Element 1 was the initial trial, which has shown that okay, OCT is the one which is able to have the diagnosis of malapposition, under expansion, and the edge dissection, and it changed the stress the way the PCI operator do. It changed the decision making. Element 2 was the one where the OCT was compared with the IVUS, and then there was no significant difference between the two, but the stent expansion and stent malapposition was not, stent expansion basically was not properly assessed with the OCT compared to the IVUS, which was clarified in element 3, where the external elastic lamina based assessment was done, and it was found to be non-inferior to the IVUS guided PCI. It was also found that there is a similar degree of stent expansion and a minimum stent area in both the arm, whether it is the IVUS or the OCT one. Element 4 is the recent ongoing trial, a multi-center, multinational trial which is going on, and the PGI is one of the center where the objective is to demonstrate the superiority of OCT versus angiography guided PCI in those with a high risk clinical characteristic and the high risk angiographic lesions. As we all know, role of IVUS and OCT is there for stent optimization. It's a pre-intervention just to assess the plaque characteristic. For the post-intervention, it's the stent optimization, and at the follow-up, when there is the stent failure, one can have an idea about the how the neointimal hyperplasia is there and what's the reason, whether it's a stent under expansion, malapposition, etc., which can be very well assessed by these two imaging modality. Something about say calcified plaque, which is very important for percutaneous intervention. The extent of calcification across the plaque, erythematous plaque, can give an idea about which type of strategy you are going to use during the PCI. A low calcific burden, one can very well go with a direct stenting. A moderate calcification with a semi-compliant balloon, and those with a high calcium where the depth and length of calcium is too much, one has to have an adequate plaque modification by, say, scoring balloon, rotational atherectomy, and recently with the intravascular lithotripsy. So this particular study gives a scoring system for the extent of calcification, which can be very well assessed by the OCT. And this is the maximum calcium angle, which is a calcium arc in case it is more than 180 degree, thickness more than 500 micron, and length more than 5 meters. So these are the three criteria, including the 4 points. In case it's a 4 or more than 4 points of score is there, which needs the rotational atherectomy. Those with a less than 4 score can be taken care by, say, scoring balloon or non-compliant balloon. Here I want to say that the depth of the calcification can only be assessed by the OCT, as IVUS doesn't penetrate beyond the calcified plaque, and therefore on the basis of the IVUS one can have an idea of the calcified plaque with its length and the arc of calcification. There is certain limitation about this scoring system because it cannot assess about, say, calcified nodule and its significance during the PCI. Calcified nodule are frequently being noticed in those with a chronic stable angina, but then daily it can be there with acute coronary syndrome as well. This particular case had an acute myocardial infarction and then had an unsuccessful PCI outside, been referred to my institute, and we had an OCT guided successful PCI using the rotablation. If you see the OCT picture, you can very well visualize the calcified nodule protruding into the lumen and creating the problem during the PCI, which were very well ablated with the rotational atherectomy. So this imaging to help to treat this subset of patients who do have, say, calcium sheet and calcium nodule, where the therapy like rotablation, and then there is also a risk of, say, rotawire bias in such type of eccentric calcification, which can be very well assessed, and one can appropriately use either rotablation or IVL therapy in such type of lesions. This is the well-known diagram to have an idea about how the PCI optimization is been done. So minimal stent area should be, say, more than 4.5 to 5 millimeters square whenever you do put a stent across a major proximal coronary artery. And then the stent expansion should be at least 80 to 90% comparing the distal reference or proximal reference. The malopposition, which can be very well assessed with the OCT, should have less than 400 micron in the distance, and the length should be less than 1 millimeter. There should not be any thrombus or plaque protrusion across the stented segment. And this is very important that the plaque burden, which mainly includes the lipid pool, should be less than 50% both proximally and distally to prevent the geographical mismatch and the risk of, say, in-stent restenosis at follow-up. Regarding the SD section, it should be, say, less than 60 degree. It should not extend into the media. It should be intima base, and length should be less than 2 millimeter. In case this parameter is on the higher side, one need to put a extra stent across the edge of the previously deployed stent. So these are the various criteria which has to be used during the PCI optimization. So this is about certain recent advances regarding the, say, plaque modification by extensive drug therapy, which includes high dose of statin. One can very well assess the thickness. This particular case been taken from the net, where the fibrous thickness was 110 micron initially. With the aggressive lipid lowering therapy, the fibrous cap thickness increased to 320 micron at follow-up in the both IVUS and also in the OCT examination. So here, with the aggressive lipid therapy, one can very well assess how the atheromatous plaque with a high lipid content with high atheroma can regress at follow-up. In addition to the OCT or intravascular imaging, it's the near infrared spectroscopy which can very well clarify, like in the index case, which can be taken from one of the publication. The baseline FFR across the modality was 0.74 with the area of 5.6 millimeter square on the IVUS, which increased to 0.78, and also the area of 5.5 millimeter square following the aggressive lipid therapy. And then it's the spectroscopy, which gives an idea about the lipid core burden index, which has markedly decreased compared to the baseline. So drug therapy evaluation at follow-up can be very well assessed by the intravascular imaging. This is a very landmark trial, the Prospect trial, which has studied non-culprit lesion in patients with acute coronary syndrome who underwent 3-vessel grayscale and virtual histology intravascular ultrasound imaging after the successful PCI of culprit lesion. So mine over here, these were the lesions which were not significant angiographically. They had an FFR value more than, say, 0.8, and then they were assessed with the intravascular imaging. And what it was found that those lesions, those insignificant lesions who had a clinical event at follow-up were the one who had a presence of thin cap fibroathyroma, a plaque burden which was more than 70%, and then the minimal luminal area of less than, say, 4 millimeters square. So this is a certain new area where one has to have an idea about which vulnerable plaque or which insignificant lesion is going to have a problem at future, can have a clinical event at the future, and they should be aggressively managed and treated at appropriate time. So regarding the clinical application near IVUS is that it's helped to identify and localize the vulnerable atherosclerotic plaque which is a clinical tool and could help in precise lesion length, including segment with a lipid-rich core burden towards optimal stenting. As I initially mentioned, less than 50% plaque burden should be there, but in case it is high lipid content, and in case it is vulnerable plaque at the edge of the lesion, it should be well covered with the stent. The knee could provide about the information of the necrotic core of atherosclerotic plaque, which cannot be assessed with the IVUS or OCT, and can predict the embolization distally, resulting in slow or no flow phenomena, or can result into say peri-procedural myocardial infarction, which in turn is going to cause a high clinical event at follow-up. This new imaging modality is also going to be helpful to assess the possibility of future coronary event based on lipid content index of the non-culprit segment, and offer a unique diagnostic utility and a risk stratification tool for monitoring the effect of statin and also PCSK9 inhibitor in coronary vasculature. Regarding the role of imaging in the bifurcation, PCI, one of the meta-analysis which was recently published of 7,800 patients has found that there is a significant difference in the cardiac death between IVUS-guided PCI versus angiography-guided PCI. So imaging do help uh, in improving the clinical event, including the cardiac death in case it is to be used for bifurcation coronary PCI. It has also been found that those with the two stent, it is preferable and advisable to have the imaging compared to say provisional stenting where one can have the PCI without the imaging. But note that imaging do always help. We do have enough data that shows that imaging always help to improve the clinical outcome and also the angiographic outcome in those patients who have the complex bifurcation lesion, left main lesion, and other complex lesion as well. We at the department, along with Ganesh, one of the organizing committee member, has studied the bifurcation coronary lesion, and that found that OCT do help to have an idea about say stent malopposition, which was found to be more frequent in those with the those bifurcation lesion where we had two stent stress A compared to provisional one stent stress D. Role of say contrast-free imaging. So there is a role of Dextran, and our department has published a paper regarding use of Dextran during the OCT to reduce the contrast load, which is of course required in those patients who have LV systolic dysfunction or at the risk of contrast-induced nephropathy. So Dextran in our experience is found to be equally effective with a good imaging quality as compared to contrast, and then this can be an alternative to contrast use in those patients where there is a limitation for high doses of contrast during the PCI. Another study along with the Army Hospital Delhi, which has been published in the Indian Art Journal about the role of saline, and this is also found to be effective for adequate imaging of various lesion and stent optimization uh, in the patient who require a less amount of say contrast during the percutaneous intervention. So at last, let me summarize. The intravascular ultrasound is in the picture since say 1998 when studies were started. It is in routine use from 2006 when ACCH has recommended that it's a class 2A indication for its use to have a stent optimization. Recently, the ultimate study and IVUS-XPL study has shown that the MACE rate has a drastic improvement, a significant improvement following the use of IVUS during the coronary PCI. So it is preferable to use the imaging during the PCI when you are going to use the IVUS. Regarding the OCT, the thing got started in 2002 when it's been used use in a human being. And then a frequency domain was started since 2008. The data are picking up for the OCT usage during the PCI, and following the element 3 and the opinion trial, we have come to know that okay, this is OCT is also comparable, at least non-inferior to the IVUS, and going to have the improvement in the clinical outcome, though the angiographic outcome is found to be favorable. ESC guideline has again recommended 2A indication for the use of OCT during the PCI. So thanks for kind attention.